Hello again, and this week's lecture is going to be covering leisure motivation and behavioral health participation. Again, this is super relevant to our field of recreational therapy. This is kind of like the bread and butter, I would say, of what we do. So let's go ahead and dive into this week's topic. So, mental health and recreation therapy. We as recreation therapists deal with, oftentimes we're going to deal with patients in mental health settings. Even if you're not directly working in mental health, oftentimes even in physical rehab or a skilled nursing facility or even a school, you might be encountering a variety of participants who may have a varying degree of mental health disorders. That includes behavioral and emotional disorders, PTSD, chemical dependency, suicide and depression, and anger management. So when we're looking at our mental health outcomes as they relate to the ICF, there's a variety of different codes. So temperament and personality function, energy and drive function, emotional function, thought functions, higher level cognitive functions, and experience of self and time functions, handling stress and other psychological demands. And you can see all the ICF codes that correspond to that next to the different outcomes. So mental health disorders are difficult to assess, and we might ask the question why. So we really must rely on the patient's answers. So really, if it's all in their head, they could manipulate their answers. So despite the difficultness of measurement, the demand for accountability still exists. So one of the slowest to develop and implement outcome measurements, and it does lack the most validity and reliability. So there is no gold standard measurement that exists, and that's because of kind of what we talked about. They're hard to measure. You're strictly relying on the patient. So just some things to keep in mind. First, we're going to talk about loneliness. So there is a scale to measure loneliness, which is a UCLA loneliness scale. It measures feelings about relationships, social support, and connectedness. It measures that assess how often a person can feel disconnected from others. So we can look at the different populations that we might use this most in. That would be homeless youth, teen mothers, and Latino immigrants living on a low income are those that are most vulnerable, but obviously there's other populations as well that we can explore using this scale. And here are the instructions on scoring the measure. So you're going to use a 4-point rating. 1 is never and 4 is always. That's going to be a Likert scale. Participants are going to answer 20 questions such as how often do you feel left out and how often do you feel part of a group of friends. The researchers are going to reverse code the positively worded items so that the high values mean more loneliness, and then they're going to calculate the score from there. So why does loneliness matter? So studies show that people who have high scores on the UCLA loneliness scale tend to have trouble in other areas which are related to social mobility. So for example, people with higher loneliness scores often have worse friendships and romantic relationships than people with lower scores. It's also related to a variety of other things such as job burnout, chronic illness, physical inactivity, and early death. So loneliness is real and is definitely something that we need to help work to address as recreation therapists. So next we're just going to talk about some RT behavioral health assessments that are specific to our field. So the first one we're going to look at is the comprehensive evaluation in RT, or the Psych-R. This is how we use social skills to integrate into society. There's 3 performance areas. There's general attendance, appearance, attitude toward recreational therapy, individual performance, decision-making ability, expression of hostility, performance in organized activities, performance in free activities, attention span, frustration, tolerance, strength, endurance, and group performance, as well as leadership ability in groups and group conversations. It was developed to meet the need for a reliable, valid, and practical tool specifically for the mental health populations. It also focuses on observable behaviors rather than self-report, which is essential when clients have impaired insight or communication. So kind of like we talked about before, it is hard to assess because it's in their head, but as RTs, we can really watch what the clients are doing and kind of see how they're reacting to certain situations. So in looking at the general area, we're looking at appearance, posture, and attendance. That's going to be on a scale of 0 to 4. So the 0 is going to be attends, 4 is refuses or never attends. Appearance is going to be for ratings 2 or 3. We're going to underline the behaviors being rated as appropriate as a 0. 1, meaning disarranged clothing. 2, suggestive dress or any wrinkled and spoiled clothing, which could be indicative of mental illness. 3, very meticulous or very wrinkled and spoiled clothing. 4, very wrinkled and soiled clothing. And then the attitude towards RT or recreation therapy. 0, we can classify as enthusiastic. 1, interested. 2, indifferent. 3, intense dislike. 4, hostile. We can also look at coordination. That's 0 to 3. From 0, well-coordinated gait, to 3, spastic or draws attention. It's related to individual performance. We can look at judgment ability. 0, good ability, to 4, no ability. We can look at ability to form individual relationships, and we're going to evaluate that after 3 days. So 0 is relates readily, to 4, rejecting. Expression of hostility, A or B. So 0, appropriate, to 4, physically combative, and then everything in between. Then we have performance and organized activities. 0, grasp situation. 1, needs minimal instructions. 2, needs frequent instructions. 3, needs constant instructions to participate, or 4, is unable to participate. Performance and free activities, that is to be evaluated from evening and weekend activities. 0, acts on own initiative all the way to 4, which is no interest in or refuses. Attention span also is a 0 to 4 scale. Attends an activity, to does not attend, and everything in between. Frustration and tolerance level, 0, participates without appearing frustrated, to 4, so frustrated that they're unable to participate. And lastly, strength and endurance. So that is 0, having good tone, to 4, being unable to participate. When we're looking at group performance, that is looking at cooperation, leadership, and conflict. There's a total of 25 items. Each of them are rated on a 3-point scale. So 0 is major limitation, 1 is a moderate, and 2 is no limitation. The higher scores are going to indicate greater functional ability. Again, going back really quick to the last assessment we were just talking about, it is observation-based and it is conducted during recreation, leisure activities, or structured sessions. It's also going to be typically created over several encounters, and it's going to want to capture a particular behavior. So those are all things to keep in mind with that Psych R. It is a cornerstone assessment in behavioral health and recreational therapy, and it emphasizes direct observation, structured scoring, and treatment planning. It also enhances the CTRS's ability to demonstrate their clinical effectiveness and support client outcomes, which is always important for us in the field. So moving on, we're going to talk about the Therapeutic Activity Assessment, or the TRAA. So the establishment of a TRAA originally was piloted with clients with Alzheimer's. Burlingame noted the assessment is one of the best for use with people who have severe mental illness. It can also be used with geriatric and geropsychiatric clients, so those older adults in psych settings, which is very exciting. The target populations that this is typically going to work with is to identify barriers and strengths so recreational therapists can design activity-based interventions that promote independent and meaningful leisure involvement. And the populations are typically adults and older adults in rehab, long-term care, or community settings who can follow simple verbal directions. It's also very valuable in clients that have cognitive or communication impairments that make self-report questionnaires difficult. And these are smaller populations, so clients with TBI, developmental disabilities, psychiatric disabilities, people receiving supported care, like skilled nursing, residential facilities, and all of that. So some of the assessment tasks are a card matching game, which is really going to be that fine and gross motor skills, can also be cognitive, simple non-strenuous physical exercise, and an arts and crafts project. You can see some of these tasks if you click on the link to the YouTube video below. And some barriers to participation in this assessment might be mental illness symptoms, lack of motivation, maladaptive coping, or environmental and social support limitations that they may have. And this leads to promoting engagement in RT, so adapting interventions to the individual motivation. Examples of goal writing that target increased participation is important, and encouraging autonomy and self-determination are also important. So limitations and considerations for this assessment as well is that it requires a trained CTRS for accurate observation and scoring, and it is best used alongside an interest or preference inventory to capture what the client wants to do, not just seeing what they can do. Some of the strengths also of this assessment are that it is observation-based, and it's great for clients with limited verbal skills, as we mentioned. It's holistic. It evaluates physical, cognitive, communication, and effective functioning together, and it can be completed within a single section, which is always helpful. It is a practical and efficient assessment that blends a functional evaluation with leisure relevance. And this is through identifying barriers across the motor, cognitive, communication, and affective domains. So with this, the CTRSs can create a targeted evidence-based intervention that really helps to foster independence and meaningful recreation. So all good things with these assessments related to rec therapy. So thank you all for hanging out and listening along, and I will talk to you soon. Feel free to reach out with any questions, comments, or concerns. Thanks.